Good morning, everyone. We are just going to wait for a couple of minutes for more people to join in, and then we will start with today's episode of Surgeon's Perspective. Hello, and I welcome all of you to the ninth episode of A Surgeon's Perspective, a Facebook Live series in which we sit in for a conversation with renowned surgeons from the medical fraternity and have a conversation with them about common misconceptions, doubts people have about their respective field of expertise. Today's episode of Surgeon's Perspective, we are going to talk about shoulder pain and instability. When we talk about shoulder, in geriatric, in elderly population and in young population, shoulder is a joint which is impacted very commonly. In geriatric population, problems like frozen shoulder or shoulder pain, shoulder arthritis are common. And in younger population, uh, rotator cuff tears and shoulder instability. So these problems are common. So today we're going to talk with our surgeon. Today we have with us Dr. Nilesh Kamat, a renowned shoulder surgeon from Sancheti Hospital. And we're going to have a discussion with him about what are the common problems that affect shoulders in elderly as well as young population, and why does it happen and how to manage them. So let's welcome Dr. Nilesh Kamat to our ninth episode of A Surgeon's Perspective. Good morning, Dr. Kamat. Thank you so much for joining us today.
Hi, good morning. Good morning, Dr. Saurabh. At the outset, let me thank both Healyos and Sancheti Hospital for this fantastic initiative where I think patient education base is what is most important. And hopefully of this discussion, we would be able to get our patients to understand the pathologies better.
Right, right. Very true, very true. So before we dive into this conversation, first let's talk about what are the most common shoulder problems.
Well, I think that's an interesting question simply because shoulder joint has the distinction of different conditions affecting different age groups. So what I mean by that is, let's say if I have a young patient, someone who's in his second decade of life, the most likely thing that he would present would be something like a shoulder dislocation or instability of the shoulder. As opposed to that, if I have someone who's more than 60 years of age, the chances of him having a recurrent dislocation of shoulder is going to be much lesser as opposed to having a rotator cuff pathology or arthritis. But offhand, if I were to actually enumerate what are the common shoulder issues, well, I would suggest probably instability at the top of the list, followed by rotator cuff tears. Frozen shoulder is something which is very, very common, and the masses would kind of agree to that. Likewise, overuse related gym injuries. So, what we would diagnose them as tendinitis, and what would actually be called by patients as overuse injuries or sprains. And I guess lastly, arthritis. So, that would complete the entire spectrum of injuries as far as what would present in the shoulder OPD.
Right, very true. So you just mentioned frozen shoulder, which I think we all will agree is the most commonly heard word or terminology as far
Absolutely.
as people above 45 years of age is concerned. So my next question
True.
is about frozen shoulder. What are the contributing factors to frozen shoulder?
It's if I were to give you something of a humorous condition here, in our residency days, and we're talking 20 years back, at that point of time, practically every shoulder pain was labeled as frozen shoulder, right? So that's what shoulder surgery has evolved as much. And even
Right.
now, the enigma of frozen shoulder still remains. See, this entity was described by a great shoulder surgeon called Codman in 1930s. And then he had given the definition that it's a condition difficult to define, difficult to treat, and difficult to explain. We are nearly 100 years down the line. And even then, I would say that, yes, it's very difficult to explain to patients that you have a frozen shoulder and this is going to take that much time. But
Right.
if you were to ask correlation, that means which conditions or what other things are contributing. I think diabetes or hormonal imbalance is something which is very commonly affected. So, to give you a perspective, if I'm looking at the incidence of frozen shoulder in the normal population, we are probably looking at around, say, 3 to 5%. As opposed to that, in diabetics, it's around 20 to 25%. So
Right.
if you're a diabetic, there is nearly a threefold or a fivefold chance of you having or developing a frozen shoulder. But
Right.
having said that, the corollary is not true. That means every pain in the shoulder is not a frozen shoulder. So you need
Right.
to get that evaluated. Likewise, sometimes you have a simple jerky episode or a traumatic episode, and that can trigger off a cascade of events which can lead to frozen shoulder.
Right.
And many times it's actually there's no reason. So it's effectively an idiopathic shoulder, right?
Right.
But I wouldn't categorize a post-surgical stiffness as a true frozen shoulder or a post-traumatic stiffness as a true frozen shoulder. So frozen shoulder is a distinct entity which has been described, and it has a different set of issues altogether,
True.
right?
True.
So that's how it would be.
Okay. But in a nutshell, we can say that people who are diabetic, people who are above the age of 45, should be more careful when it comes to shoulder, because the onset of frozen shoulder could be more in them.
Right. So when do you pick them up, right? Yes, and rightly said that it's very common amongst diabetics. So if you look at a classical frozen shoulder, it is run through three different phases. The
Right.
first phase is what is known as the phase of inflammation or the freezing phase, where
Right.
patients are present with good movement, but typically the terminal range of movement will be painful. Night pain is the hallmark, and
Right.
sudden jerky movements are immensely painful. That these are the three main hallmarks in the freezing phase. And the pain is more so on the outer aspect of the arm. This is how they would present to you.
Right.
This goes on to a second phase, which is your phase of stiffness or the frozen phase, where actually the pain component goes down, but they start losing out on movement as well, right?
Right.
And why this is extremely important is because patients panic on this that when they come back to the clinic and they're like, Doc, I've been undergoing treatment and I'm losing out on movement. But well, that's the natural cause of the disease process.
Right.
Because following the frozen phase, you have the phase of resolution where effectively everything comes back to normal. Now, what is the challenge is that each phase can actually last for a good 6 months and beyond. So
Right.
effectively, the entire cycle can very well take 1 to 1.5. In fact, in literature, there are some weird case reports which talk about going as much as 8 to 10 years. But that's a rarity. But
Right.
effectively, yes, by and large, most of the patient population would have a frozen shoulder lasting for, I would say, around 12 to 16 months. That's the
Right.
rough range that we're
Right.
looking at.
Right. Okay. And as you mentioned in the passing, that a lot of shoulder pain after a certain age is categorized as frozen shoulder, and now it has become a very household name, frozen shoulder. So any shoulder
True,
pain, even patient comes to us who are saying that I have had a frozen shoulder. So what are the
true.
differentiating factors for people to understand what they are having might not be frozen shoulder, might be something else? So are there
So
any factors that people can understand on their own?
So I think, yeah, this is something which you don't want to overlook this and you would want to seek treatment earlier.
Right.
When you're looking at night pain, when you're looking at that jerky component, as I said, is extremely painful, right?
Right.
These are the hallmarks in the initial phase. When you start having these conditions or when you're having these symptoms, I think it's worthwhile to seek a medical opinion because sometimes the commonest condition which mimics the frozen shoulder is a rotator cuff tear. And
Right.
here it's a question of missing the bus because if you don't pick up a rotator cuff tear earlier and you don't treat it faster, understand the implications of the outcome is that much more delayed because the management is completely variable when it comes to a traumatic rotator cuff tear vis-a-vis a post-trauma developing frozen shoulder. So I think night pain and jerky movements, which are very painful, these are two things which patients should not overlook.
Okay, perfect. I guess that's a very important, valid point. It's important to get it assessed so that a right treatment approach can be given to the patient. Very true. So while we are on the topic of frozen shoulder, can you give us a few tips about the management of frozen shoulder?
Okay, that's like a symposium which can go for days. Okay,
Right.
but let me put it in very simplified words. Commonly, it is believed that taking painkillers or doing physiotherapy this is the only answer for frozen shoulder. But if you actually look at what literature has to say, what we commonly use as painkillers is the non-steroidal anti-inflammatory drugs, right? If you were to look at the evidence-based approach, the
Hmm.
NSAIDs do not alter the natural history of the frozen shoulder. So
Right.
why do we give them? We give them for symptomatic relief, right?
Right.
But if I were to enumerate the treatment options for frozen shoulder, in the initial period when it's painful, actually rest is something which is helpful. You can take NSAIDs or painkillers as and when required for managing the pain. Sometimes you have to actually do to relieve muscle spasms. You can do dry needling, or you can do the so-called acupuncture, which specialist physios like yourself do.
Right.
Likewise, you can go ahead for some range of motion exercises. But the important thing is when you're doing physio, you need to keep them in the pain-free range rather than trying to push them for range in the inflammatory phase. If you
Right.
think about modalities like interferential therapy, like doing local ultrasonics, that would help you with symptomatic relief.
Right.
If patients are not responding to pain, probably that's where doing an intra-articular or a subacromial shoulder injection. And I think this is something very important because a lot of patients have a mental thought process that no, I don't want to get an injection done. It's a steroid injection. But
Right.
what they need to understand is that this is a very locally acting uh, injection, and it's not going to have any kind of systemic absorption. It's one of the most proven forms of treatment of frozen shoulder as far as pain management and pain relief is concerned. And when then done appropriately, you can expect a predictable outcome.
Right.
Surgery is probably the last resort when it comes to frozen shoulder. So, if I were to give you a figure, let's say if I say 100 frozen shoulders in a year, I might land up operating one or probably 1 in 2 years also, or 2 in 1 year. So
Right.
that's how less 1 to 2% is probably what I'm looking at when it comes to intervention for a shoulder frozen shoulder is concerned.
Right. Perfect. Thank you so much for that. And I guess in your answer, there was a very important tip for all the physios that are watching. You don't push it in the initial phase of inflammation. Don't push the shoulder to the pain range. Like keep the movements to a pain-free range rather than pushing it beyond, which is, I guess, a very important tip for all the physios. All right. So moving to the next common problem that you mentioned, which I guess in an elderly population, let's focus on first is arthritis. So how, when it comes to knee, everybody knows that knee undergoes arthritis. How common is shoulder arthritis, and how to identify it?
So it's surprising that many patients who come to us in the outpatients have early arthritis, and
Right.
we have imaged them for some other reasons, but they are not as symptomatic. And the reason being that the knee is a weight-bearing joint, the hip is a weight-bearing joint. So with
Right.
every step, you're loading that joint, and you are realizing that it's painful. As opposed to that, a shoulder is a non-weight bearing joint. It is meant more for mobility rather than to load the shoulder. So it
Right.
is very well tolerated. But if I had to
Right.
put a figure as to what is the incidence of arthritis, I would say probably incidence of arthritis could be as high as 15 to 20%. And I'm
Hmm.
talking about primary arthritis of the shoulder. Now, when you're looking at arthritis, sort of we could basically divide it as either primary arthritis, which is
Right.
the age-related wear and tear. You can attribute it to a post-traumatic arthritis. That means someone
Right.
who's undergone surgery, and for whatever reason, unfortunately, the surgery is not gone well, or there's been a complication, or the fracture configuration was such because of which there has been an arthritis. And
Right.
thirdly, there are inflammatory conditions where you can have autoimmune reactions affecting the shoulder, resulting in arthritis. And
Right.
lastly, because of structural damage, that means you can have a rotator cuff tear because of which it has been neglected. The biomechanics of the shoulder are disrupted, and that leads to an arthritis. So it's a huge
Right.
spectrum. But
Right.
what patients are more bothered about is, do I have arthritis? And when they say arthritis, it's about the primary osteoarthritis, which affects the knee and the hip. Well, you're looking at probably around 15 to 20% of patients.
Right. Right.
That's what the incidence of arthritis is.
Okay. Okay. Understood. So moving on to the younger population, as you mentioned, rotator cuff is something which is very common. So I have a couple of questions in follow up to rotator cuff, but let's first our audience let them understand what is rotator cuff tear and how does it happen.
Okay. So in fact, so I'll just make a correction here. Rotator cuff tears happen always or most likely to happen in the elderly, not in the younger population.
Okay, okay.
And and
Hmm.
simply because so rotator cuff is not a one single muscle. It's a group
Right,
of muscles, and you have four muscles, namely the subscapularis, you have the supraspinatus, the infraspinatus, and the teres
right,
minor.
right,
The subscapularis is in the front of the shoulder, which results in internal rotation, and the remainder three result in one is overhead activities and for external rotation.
right,
Now, what you need to understand is that they all work in tandem, and when they work in tandem as a team, the principle of their working is to keep the humeral head centered against the socket. That is what it
right,
is. When the
right,
head is centered against the socket, that is when your main muscle of the shoulder, that is the deltoid, is responsible for lifting your hand up.
right,
Now, when this centration effect is lost of the rotator cuff because of a tear or dysfunction, then the deltoid cannot lift the arm. As a result, a patient is trying to shrug his shoulder. So,
right,
rotator cuff primarily centers the head of the humerus against the glenoid. That means keeps the ball in its position against the socket and allows the deltoid to take your hand all the way up. That is how the functioning is.
right. Okay. So I really wish that you were there to teach us this when we were in college. I have never heard a rotator cuff tear being explained so simply and so well.
I think
Uh,
this is something even our postgraduate students, right, when we discuss this with them, uh, the understanding is always to check for abduction, but why are you checking
right,
the abduction? That is what is important, right? So
right,
yeah, so that's as far as the functioning of the rotator cuff is there. Now,
right,
why do rotator cuff tears happen? Because that's your sub question as I can see it.
right.
Now, if you look at the insertion of the rotator cuff right on the socket, the
Mm-hmm.
last 1 to 1.5 centimeters, it does not have good blood supply. So that's the
Right,
so-called critical zone, right?
right,
And after the age of 45, 50, this tends to diminish further. So
right,
imagine if you're doing some overzealous activity or what is known as an eccentric loading of the rotator cuff. If I were to give you a simple example, think about it that you are traveling, you're supposed to put in your so-called 10 kg bag in the overhead bin in an aircraft, and you're going to
right,
yank it up and put it up. Now that
right,
is eccentric loading of the cuff, and that can result in a tear of the rotator cuff.
right,
Likewise, I'll give another example. Let's say you're traveling and you are holding on to an armrest in a bus, and suddenly
mhm,
the bus brakes and your entire body weight moves forward, and that
right,
can result in a rotator cuff tear. Now, why am I mentioning this? Is because patients fail to identify a traumatic episode with a rotator cuff tear. Most of these things are subtle traumas, right? They are
right,
not like injuries like you've fallen off the bike or you've had a big fall or so on and so forth. But yes, effectively, this is categorized as a traumatic rotator cuff tear. And the primary pathology is because there is poor blood supply. So this is
right,
one set of patients. Now, the other set of patients is totally different. They are the ones who present in, say, 65, 70, and
mm,
beyond, which is a degenerative cuff tear, where a
right,
patient has not had a fall but has been repetitively overusing the shoulder, and there is a rotator cuff tear. Now, these patients don't present as sudden pain. They are like
right,
slow, gradual pain, and they respond very well to physiotherapy.
right,
So, if I were to broadly categorize it, you're looking at a traumatic rotator cuff tear and you're looking at a degenerative rotator cuff tear.
right,
The traumatic rotator cuff tears are the ones which tend to progress and they may require surgery. As
right,
opposed to that, the degenerative rotator cuff tears, they are the ones which are who are amenable to physiotherapy, who can expect a good outcome. Why?
right,
Because if you look at the general population, at the age of around 60, probably if you go out and get MRIs done for everyone, there is nearly a 15 to 20% chance that there could be a rotator cuff tear and you don't have any symptoms.
Right.
And mind you, this number keeps on increasing. So by the time you are, say, 85, there's nearly a good 25 to 30% of normal population who would have a rotator cuff tear, right?
Right.
So identifying the cause is prudent when it comes to management of rotator cuff tears, right?
Okay, understood. Thank you for explaining that in so much depth and detail. So next common problem that you shared at the start of the conversation was shoulder dislocation, and this is something which is very common. A lot of people have recurrent episode of shoulder dislocation, and they just get habituated to fixing the shoulder back in the socket and think which is it is very normal. So I just want
Right.
our audience to know a bit more about what are the causes of shoulder dislocation and why is it so common?
Okay, so let's come back to the sub question first. Why is it so common, right? Now
Mhm.
you would agree that as a physiotherapist, you know that the shoulder is the most mobile joint in the body, right?
True, true.
Now, nature is in such a manner that if you have mobility, your stability will go down. Now,
Very true.
let's take an example of the hip joint. The hip joint is something which is meant for weight bearing, correct?
True.
So it is meant to load. It is an extremely stable joint, but the mobility of the hip joint is not as much. Now, why
True.
am I giving the example of a hip joint? Is because even that is a ball and socket joint. But
Right.
as opposed to that, the shoulder, because it is so mobile, because the mobility goes up, the stability comes down. That's
Right.
the reason why it is the most commonly dislocated joint as well. Now,
Understood.
coming to causes, now why does a shoulder dislocate? Now, there could again be a differentiation between a traumatic and an atraumatic. Let me touch upon the atraumatic, which is the less common, and then go on to the traumatic. Now,
Right.
what is the atraumatic? It is also called as multidirectional instability by and large. What does that mean? It means that the collagen tissue, that means your own body tissue, is extremely stretchable. There are
Right.
certain criteria which has been described in literature, wouldn't divulge details of those, but it's simply where your thumb can touch your forearm and so on and so forth. Now, when your collagen tissue is excess stretchable, these patients, if their muscle tone is not good enough, they can actually pop out and come back in. And it's
Right.
very important for them to have good muscle strength so that the muscles take over the function of ligaments or supplement the function of ligaments, and the dislocations don't happen as well. They are
Right.
the multidirectional instability. As opposed to that, there is the so called traumatic dislocation where the first episode is because of a trauma. And when there is trauma, obviously something is going to tear and is going to jump out of its position. So
Right.
when the traumatic episode takes place, the shoulder has a surrounding boundary wall called the labrum. And
Right.
if that labrum tears along the front aspect, understand that effectively it's something where it's a field without a fence. So as soon as you do this, that is an abduction external rotation maneuver, because there is no boundary wall, you're going to pop out. So that's
Right.
the traumatic dislocation, which happens typically in the second decade, third decade. And those are the patients who more or less are requiring surgery if it's a recurrent dislocator. So
Right.
if it's a primary dislocator, that means it's dislocated it for the first time. Until and unless he's an extremely high demand athlete who's competing at a professional level, it's very rare that someone would talk about surgery in the first consult. You would like to
Right.
image that and see things. So if it's a first dislocation, you would set it back in its position, let the structures heal, and hope that it does not dislocate. But yes, if
Right.
it becomes a recurrent dislocator, which is post-traumatic, then by and large, there is a high chance that you may require surgical intervention.
Understood. Okay. So you've okay. So moving on to the another common injury that you mentioned, which is in a gym or athletes that suffer from it. So why shoulder injuries are common in gym, and how is there any prevention measures for that which gym goers or fitness enthusiasts can keep in mind?
I think this is a very relevant question simply because quite a few, a significant percentage of patients whom we see in outpatients are related to overuse injuries, and not just gym, even in the house if they're exercising. Now,
Right. Right.
what what we need to understand is, and probably all of us are guilty of this fact, that when we hit the gym, it's wanting to get more about those higher weights and trying to develop more muscle bulk rather
True.
than trying to pay attention to the arc of the range of motion. It's
Very
about how you're initiating that muscle contraction and how you're maintaining the arc. Because you may still get the weights to go up, but if your arc is not right, there is a higher chance that you're going to develop an injury. This
true. Right.
is by and large the rule of thumb. Now, the second thing which is very
Just sorry to
important.
interrupt. Can you just explain to our viewers what do you mean by arc of the movement?
Okay,
Because
so
that's a very
let's say
important
that.
point for them to understand.
Agreed. So let's say that if I'm doing a dumbbell fly, right? Now
Right.
the shoulder blade, the scapula is not absolutely parallel to my body. So if my body is like this, the scapula is at an angle of around 30 degrees or so. So when
Right.
you're trying to get your shoulder to abduct, if you're trying to go backwards, you're going to put in a lot of load onto the shoulder, which is
Right.
not physiological. As
Right.
opposed to that, when you're working in the arc, that is the correct arc in the scapular plane, the chances of you injuring yourself are less likely. Also,
Understood.
the other thing, now this is related to free weights. The
Hmm.
other thing, what everyone should understand is that at the outset, when you are someone who's hitting the gym new, it would make sense to use the machine assisted exercises rather than doing free weights, because a machine arc is not going to change. So
Right.
at least it's less likely that as you're increasing the repetitions, that you will try to compensate and cause an injury, because that arc is going to remain more or less the same, right?
Right.
As opposed to that, when you're doing a free weight, because you still have, because your trainer is behind you and he's telling you no, finish 15, and he's pumping you up, you would
Right.
still try to finish that set, but in that process you might injure yourself.
Very
This
true.
is one aspect to it. The other aspect to it is, if you really want to know the key of preventing an injury, a tight muscle is always the one which tends to get injured. So
Very true.
if your muscle is not tight, that means if you're stretching well enough, if you don't have tight capsule around the shoulder joint, the chances of you sustaining an injury, I'm not saying they're zero, but at least the chances of you sustaining an injury are much less as compared to a tight muscle. So, and this is a rule of thumb for not just the shoulder, probably for all muscles in the body, that if you don't have a tight muscle, you are less likely to injure it.
Right. Very true. So basically, flexibility is something, a component which is
Absolutely.
normally underrated and ignored. People should start focusing on that and take a good amount of time to do stretching exercises so that your chances of injuries are reduced.
Absolutely. Absolutely.
All right. So now, to all our audience, we are almost coming to the end of our conversation. So, in case you have any questions that you would like to ask Dr. Kamat, please start putting them in comments, and I'll ask the relevant questions to him. So, this is almost the last question that I have. What is the importance of physiotherapy according to you in rehabilitation of shoulder injuries, let's say post surgery, or in case of soft tissue injuries without a surgery? What is the importance of physiotherapy rehabilitation in shoulder?
Well, I guess, okay, let me sum this up by one statement. I'm half as good a surgeon that I am in the absence of a good physio department. Okay. And I think we are blessed to have a dedicated shoulder physio unit which caters to a lot of shoulder issues. So, okay, let me put it like this, that if we see 100 patients in the outpatients, probably only 10 would require surgery, right? The
Right.
remaining 90 are going to require the correct exercises. And I firmly believe that medicines is not the long term answer. It will help you tide over the acute discomfort, it will help you get symptomatic relief. Because in today's day and age, you want to resume back to your activities faster, you can't be off work. So that's where medicines will aid you, but no
Right.
medicine is going to get a tissue to heal completely. It might suppress the inflammation, but then that's when you're going to work it up. That's why you're going to do the stretching, you're going to do the rehab exercises, you're going to do the modalities and still get a fantastic outcome. So I think
Right.
kudos to all the physios who follow this principle and help in treating shoulder pathologies, because shoulder is complex. It's not a unidirectional joint. It is made up of multiple muscles. And just as an oversight, if I were to tell you that shoulder is not just the ball and socket for us, you would agree for your perspective as well.
True.
A shoulder for a shoulder surgeon is something which starts right from your manubrium sternum to your clavicle
Right.
to your shoulder blade. That's the scapula, then the glenoid, and then the arm. So you're looking at a composite movement of all of these.
Very
And
true.
and the other thing which I would like to give a shout out is that many times physios are really underrated. And what I would like to submit here is that sometimes understanding of the movement is better appreciated by a physio than by a surgeon, because they see practically every patient from that perspective. As surgeons, we are more trained to treat structural pathologies. We are more trained to kind of help and guide physios and work with them together to treat issues. But as far as assessment is concerned, I would give a lot of credit to physios. And some of the physios, I have no shame in saying this, are hugely better than the surgeons themselves.
Thank you so much for saying that. And I guess that's why through the Helios and Sancheti collaboration, we always try and give such fabulous results to our patient, because this communication between a treating surgeon and a treating physio is very important. And that's, I guess, we have cracked that golden code through Helios Sancheti
True,
collaboration, and we try to give awesome results to almost all our patients.
true.
Uh, and with on that note, so we are just going to move towards taking some audience questions. So I'm just going through the comments and I'll ask you a few relevant ones.
Sure.
Okay, so we have a question from Namrita Mehta. Question from Namrita Mehta. The question is, after rotator cuff injury and the patient has undergone surgery, even after that, the terminal range is painful and of course night pain. Can we label it as frozen shoulder? I mean, the initial stage of frozen shoulder. Yes, this is a
All right.
physio
So,
that was asking the question. Yeah.
yeah, sure. So, in fact, if I were to answer that to Dr. Namrata, as I said, that if I were to look at a frozen shoulder, that would be a separate entity, and the post-surgical stiffness would be a separate entity, right? So, I wouldn't really jumble up or mix up the two terms. But if I were to simply say that it's only the terminal range which is getting affected and the patient has good strength, probably we also need to look at a capsular component, where if the capsule is tight enough and do the capsular stretches, yes, it's very well possible that there could be a capsulitis. That means inflammation of the capsule which is not allowing that range to come through. But I think I would be a little wary of labeling it as a freezing phase of a frozen shoulder, because that's a
Right.
different subset altogether.
Right. Okay. I hope Dr. Namrita that answers your question. The next question is from Mr. Pradeep Pawar. Hi, what should we do in Blanchard lesion from past profile? So he's suffering from Blanchard lesion for last 5 years. So we
All
are
right.
seeking
So,
for a
right. So Mr. Pawar is actually suffering from a condition called as a Bankart lesion. That's Bankart, which is the traumatic unidirectional instability. And that's where I was talking about the labrum which surrounds the shoulder joint or the glenoid. When the shoulder dislocates, the Bankart is the name of a surgeon who had described that lesion where the labrum is torn. So if there is a Bankart stare, that means the antero-inferior, that means the labrum in the front and below, that is torn and that is not providing stability to the shoulder. If it's something which has been there for the last 4 to 5 years, I would presume that he's having recurrent dislocation. And if he is not, well, probably you don't need to do anything. But if he is having recurrent dislocation, then unfortunately it calls for a surgical intervention to fix up that tear.
right, right. I hope, Mr. Pawar, that answer your question. And if you're suffering from it for last 4 5 years, I would always recommend to get it assessed one more time, and so that you can choose a better treatment approach for it. Okay, the next question we have is again from Dr. Namta. Can the jerk from holding the rod on a bus cause bicipital tendinitis?
Oh, yes. I mean, see, as far as tendinitis is concerned, any kind of condition which is either repetitive or a single traumatic episode can trigger off an inflammatory sequence of events which can lead to such a condition. What we need to just rule out, as we were discussing earlier, that the jerk should just be tendinitis, and it should not be a missed rotator cuff tear, right? So that is
Right.
something important. So as long as the strength is okay and the clinical signs are in favor of bicipital tendinitis, yes, there's no harm in treating it as bicipital tendinitis.
Right. And bicipital tendinitis is again a condition which is a lot of times from the symptoms that it presents confused as a frozen shoulder, because same flexion abduction is painful in bicipital tendinitis
True.
as well.
True. See, if you were to look at the shoulder, it's not like the knee, which is a superficial joint. It's a
Right.
relatively deep joint. And there is a confluence of quite a few structures which happen together, especially along the anterior superior aspect of the shoulder. So it's
Right.
impossible to differentiate them clinically. And that's the reason why threshold for, let's say, an ultrasound or an MRI is very poor, in the sense that if you're not able to assess, or if the patient is not responding, I would not hesitate in imaging it further, because that allows me to diagnose the patient further.
Very true. Very true. So Sarita is a physiotherapist that works with Healyos. Her question is, in elderly, how common is cervical spine along with frozen shoulder? Is there a correlation between the two?
So there is, okay, so if I were to look at the age subset of frozen shoulder, we are probably looking at the fourth and the fifth decade, uh,
Right.
less likely sixth and seventh decade. But that's also the overlap, especially in the fourth and the fifth decade, that cervical spondylosis symptoms can come in. Now, many times these patients do present as a radiculopathy. And for those who don't understand what's a radiculopathy, it means radiating pain along the entire arm. Now,
Right.
classically, if you look at shoulder pathologies, the shoulder pathology, the pain should limit right up to the elbow. It's less likely that it would go down along the arm. Now,
Right.
in frozen shoulder, what happens is, because the tissues are contracted, the inferior capsule is contracted. And when you're looking at your brachial plexus, that is your set of nerves which is running from the cervical spine into the arm, they can get irritated, and the lower trunk especially can get irritated, resulting in that referred pain which is coming down along the arm. And that is where it is confusing. And it is not uncommon, Sarita, that we have a lot of cross referrals from our spine colleagues, and we do a lot of cross referrals for our the other way around, to rule out and to help the patients together, to see to it that both frozen shoulder and cervical spondylosis is being taken care of. So there's a lot of overlap. Yes, I agree on that. There's a lot of overlap.
Okay. Thank you so much for answering that. So, our next question, along with the question, so we are getting a lot of good feedback and praises. Basically, the way you are explaining everything, I guess I'll agree to Miss Palaya's point, that you're explaining to like a non-medical person can also understand it so well.
Truly humbled by the comments.
Uh, can physiotherapy be advised to patients who have been diagnosed with posterior dislocation happened only once, or surgery is required? So this is again from
Right.
another physio, Dr. Hetal. Yeah.
Right. So I think, Hetal, that's a very pertinent question from the medical fraternity perspective. So the pathophysiology of anterior dislocation and the pathophysiology of a posterior dislocation are two totally different things, right? The posterior labrum is a much more vascular structure than the anterior labrum. So healing rates of posterior labrum are much better. Until unless there is an extensive tear of the posterior labrum, it's less likely that the patient may require surgery. Or if I have to put it the other way around, none of my posterior labral tears will land up on the operating room table until unless they've had a trial of physio, right? So physio
Right.
is extremely important when you're looking at a posterior labral tear. Also need to understand that posterior labral tear may be a subset of something bigger, something like an internal impingement, which is resulting in a posterior superior labral tear, and that's a different ballgame altogether. But very rarely will you see a patient with a recurrent posterior dislocation of the shoulder, as opposed to seeing a recurrent anterior dislocation of the shoulder, right? So yes, physio is extremely important for posterior labral tears.
Okay. Thank you so much for answering that. So another question we have is from Priya. Again, we're getting a lot of questions from physios today. So Priya, so is it is alarming to have clicking sounds in shoulder for a young adult?
Why the smile is because I think this is every second patient or every third patient would ask this question. Okay, so what we need to understand, a click which is painful is something which merits intervention, or it merits further imaging or assessment. A painless click which has been more or less there for quite some time is not something that I would pay too much of attention to. You can see
Right.
a lot of patients who would be having clicks and having subtle movements in the shoulder which may make those sounds, but you wouldn't really unnecessarily get onto an MRI. It's like saying that you crack a knuckle, you're not going to go and get an MRI of your knuckle done because you're cracking a knuckle, right?
Right.
But answering the question, if it is a painless click, you can be rest assured. If it is painful, yes, it is alarming.
Right. Thank you so much for answering that, sir. So there are some questions which we got on our direct messages on Instagram and Facebook. So one such
Right.
question: in case of rotator cuff repair in a geriatric person, ideally, how many weeks later would you advise ROM exercises?
Okay. So this is a very specific post-operative question. What we need to understand is that the aim of surgery when it comes to a rotator cuff repair is you're getting soft tissue to heal back to bone. As
Right.
opposed to that, when you're fixing a fracture, you're getting bone to heal back to bone. As medicos, all of us would agree that bone to bone healing is 100%. Now, that does not happen with soft tissue to bone. So, this is a very slow process. So, if you look at conventional literature, it says that it takes a minimum of 6 weeks for the soft tissue to start developing a bond with bone. But imagine if I'm going to keep my arm in a single position for a period of 6 weeks, that patient is going to be really stiff. And that's where
Right.
starting some basic exercises called the knee phase one exercises would be helpful to prevent that inherent stiffness in the shoulder.
Right.
Also, one of the common things for all the physios, that those who are probably logged in, now throughout our teaching years, a lot of emphasis has been put on the pendulum exercises. That means we lean forward and we let the arm move like a pendulum. Now, the principle why this exercise was devised is because we know that the cartilage does not get any blood supply. So you
True.
need the synovial fluid to bathe the cartilage, as a result of which the cartilage maintains its nourishment rather than keeping it in a static position. That was one of the
Right.
reasons why you do pendulum. But when you're doing it against gravity and you do it vigorously, you can actually disrupt the tear. You can actually cause more harm than good. And that's why probably putting the arm on a table and getting them to do circular motions is something helpful. So your hand is in contact with a surface, so there is no further loading or gravity is then eliminated. And at the same time, you're preventing a capsular contracture. So coming
Right.
back to the primary question, that how long would you wait? If my repair is very secure, I would wait for a period of 6 weeks before starting off with active movement. After 6 weeks, I'll start doing active assisted. That means you allow for the rotator cuff to heal, then restore their movement. When their movement is restored to at least 90-90, that is when I would start strengthening things so that now the muscle is repaired, but you need to get on strength into that muscle, and that's where the strengthening comes into picture.
Right. Okay.
Right?
Thank you so much for answering in that detail. So while we are on the topic of post-operative physiotherapy, I wanted to ask you that after a humeral head or humeral neck fracture in elderly patient, why the expected range of motion after the surgery is done is not complete, or why physiotherapist is not advised to push it to a complete range of motion.
So if you're able to get an anatomical reduction, that means if you're restoring the anatomy back to your normal status, I think you can effectively get full range of motion. There is no reason for you not to get a full range of motion. Now, what you need to understand is that if, let's say, you're treating it non-operative, you start some gentle exercises at 3 weeks. Now, you're
Right.
worried that if you try to push it further, and if the head collapses or goes into what is known as varus, then the
Mhm.
outcome in the long run is always going to be deficient. As
Right.
opposed to that, if the patient has undergone surgery and there is internal fixation which is done and that is supporting the fracture, then I think yes, you need to push him eventually to a full range, and you should not hold back on pushing on to full range. I wouldn't do that in personal
Right.
practice.
Right.
Right?
Thank you so much for answering that. That really helps to all the physios who are listening to this. Uh, so we have another question from where we can arthralgia of shoulder be healed with physiotherapy only, or is surgery required?
Okay, so Webavi, let me split the word arthralgia for you. So what is arthralgia? Arthros meaning joint, and algia meaning pain. So arthralgia is just a painful shoulder. Now we don't know the cause of a painful shoulder. Understand, arthritis is different, where arthros is joint and itis is inflammation. So that's an inflammation of a joint. So many times arthralgia is something which is a subset or a part and parcel of the inflammation. And if it's just an inflammation which is an inflammatory type, then I wouldn't really think about surgery, at least in the initial period, until and unless this is something which is long standing and the cartilage is eroded. And at that point of time, some intervention may be required. But by and large, you can safely take that arthralgia of the shoulder can be taken care by physiotherapy and medication rather than by surgery.
Right. Thank you so much for answering that, sir. So that's all the questions we have. This is something which I am forced to tell you today on a live, so I'm going to take this comment. So Purva has to say to you, thank you very much. It's been 5 years since you've operated my fractured leg, and because of you today, I can dance, run without any difficulty.
I'm glad. I'm glad, and glad to hear that from Purva. It's been a long time I've seen her, but I'm going to convey my regards to her. Thank you.
Yes. All right. So I guess that's all the questions we have, sir, and a lot of praises your way. I'll surely be sharing all the feedback with you. People have really loved today's session, the way you've explained the shoulder. Even from the physio's perspective, we are getting the shoulder was never explained so beautifully and simply. So thank you so much, sir, for taking the
Thank you.
time out on a Sunday and giving us your time and explaining shoulder pain and instability so nicely so that a non-medical person can also understand the intricacies of shoulder joint and its anatomy. So thank you so much once again, sir, for joining us today.
Thank you, Saurabh. Thank you. Thank you for having me over. And again, thank you, Team Helios and Team Sancheti. Thank you.
And to all our viewers, thank you so much for joining us. We will be coming back next Sunday with another surgeon and another perspective. Till then, do follow Sancheti and do follow Healyos on our social media pages. We do keep sharing very informative stuff through our social media handles. Thank you so much for joining us today.